Welcome to our community. I'm Michael Levy, President of the Digital Health Institute for Transformation, or DHIT for short. We've teamed up with Crowdicity and the Assist Center at North Carolina State University to launch this exciting virtual incubator. COVID-19 has created a worldwide crisis that has shaken our communities to the core. The virus's toll on human life and our standard of life cannot be overstated. However, the present crisis creates an opportunity. We can come together as innovators to create new solutions that solve real problems, not only related to COVID-19, but which can be sustained long after the pandemic. We're all in this together, and we need your ideas, your input, and your energy. We need status quo challengers, those with great ideas, potential game-changing solutions, and practicing care providers and public health officials to help us submit, comment, vote, test, and develop. I'll turn things over to my co-host Adam Curry to invite you to participate in our challenges.
Thank you, Michael. I'm Adam Curry, Innovation Ecosystem Director at the Assist Center. We've worked with thought leaders in healthcare, research, and industry to identify some of the key health challenges facing us in light of COVID-19. Through this incubator, we are presenting these challenges to the innovator community. We want all of you innovators to submit and share your ideas for solving these problems, and we want everyone, inventors, entrepreneurs, people in large companies and small companies, those giving care and those who've received care, to provide your insights on the ideas you see posted. You'll find all of the challenges presented on the welcome page. Click on Challenge to learn more and post your idea about how to address it. Also, take a chance to review the other submitted ideas and provide your own insights. You may see a chance to collaborate with someone else in the community. If so, reach out and have a deeper discussion. As we move toward the end of the incubator, we'll invite final proposals, which you can submit as an individual or maybe as a team that you've formed. And our judges panel will select the most promising proposals to move on. Now, if you're in a company or other organization with an interest in improving healthcare, we are actively seeking people like you to partner with us in this initiative. Join us as a program champion, and you can issue sub-challenges to help your organization find the right solutions. Or be an innovation champion and create an innovation award for an idea that stands above the rest. Finally, you can join us as a program supporter and let the community know that you're with us in fighting persistent healthcare challenges. Over the course of the incubator, we'll also be hosting a webinar series to inform the challenges. I'll turn it back over to Michael now to tell you more about it.
Thank you, Adam. To spark discussion and catalyze ideas to these challenges, we're hosting a series of webinars every 2 weeks that bring together subject matter experts and thought leaders to educate the ecosystem regarding the many challenges and opportunities to advance care and utilize emerging technologies. The combination of these didactic expert panels and the crowdsourcing of ideas through the incubator create an engine to propel innovations from ideation to development to impact. Upon final submission of your ideas, our ecosystem of experts and champions will review them and select winners and recipients to our challenges and special innovation awards. Here's to building a cloud community to drive ground immunity.
Welcome, everyone. Glad to have you with us this morning. Welcome to our panelists for this session of the DHIT Frequency Series, and welcome to you who are attending. A lot of thanks for joining us on this Digital Health Institute for Transformation podcast and web series, where game changers, status quo challengers, and transformers come together to share, explore, and discuss best practices, next practices, and key developments in the space of digital health. I'm Adam Curry, Innovation Ecosystem Director at the Assist Center, and your host for today's panel. If you've joined our recent webinars, you know that Assist and DHIT are partnering on this series focused on remote health monitoring. DHIT President Michael Levy is normally my co-host for this series. He's enjoying some much-deserved downtime in the mountains, and though he planned to join us, his planned escape with his family include an unplanned escape from reliable internet and cell service, so I'll be steering this week's discussion. We're really excited about our program today. We're joined again this week by an esteemed faculty member from the Assist Center, Dr. Alper Bozturk. whose research includes development of microscale sensors, actuators, and methodologies to unlock the mysteries of biological systems. We also have Dr. Stephen LaBouef, who currently serves as president of Valencell, a company transforming the science of wearable biometrics to enable impactful health outcomes. Also a market leader in supplying global brands with commercial-grade biosensors. Finally, we have a true pioneer in precision medicine, Dr. Geoffrey Ginsburg, who has spent the last 20+ years advancing care delivery through his work as the director of the Center for Applied Genomics and Precision Medicine at Duke, as well as many other programs to drive personalization of care in health systems. Our discussion today will focus on the importance of remote pulmonary monitoring for the detection and recovery of those with COVID-19 and remote monitoring's ongoing role within value-based care and precision health in the years to come. The panel mix will allow us to explore technical, clinical, and commercial aspects and the viability of advanced monitoring, and to probe the possibilities and challenges that exist for challenges now and in the future. Before we kick off our discussion, as we do every episode of this series, we'd like to recognize those on the front lines of this pandemic. To those who are fighting for their lives, to those who are fighting to save lives, and to those who are fighting to feed their families, we're here with you. Also, I'd like to thank our program and innovation champions who are supporting our COVID-19 Unites Us All web series and virtual incubator, which we will share more about at the end of today's program.
Thank you to our program and innovation champions. Thank you to Pfizer Digital. Thank you to NC Riot, Accelerate Health Ventures, and finally, Duke MedX. Thank you for working with us to make this possible.
One note before we jump in, we welcome participation from the audience. You can use the Q&A feature in Zoom to send questions over, and we'll pick a few of them to answer toward the end of our program. So getting into it, as we've discussed on this series before, remote health monitoring allows patients and caregivers to stay connected beyond an initial virtual visit or in-person visit or screening. It allows caregivers to monitor changes in symptoms or underlying health conditions and risk factors, and to provide guidance. And it enables an individual's care team to follow protocols to intervene in a timely and appropriate manner. In addition, as monitoring technologies are increasingly integrated into consumer wearables, as those wearables are able to provide more continuous data, identifying the signs of illness even before a traditional diagnosis or observable symptoms emerge may be possible. We've seen this lately, even in the popular press, including a Washington Post article yesterday, which references some local work and introduces us nicely to our first panelist, Dr. Geoff Ginsburg. So Geoff, you and the MedX program at Duke just launched your remote monitoring clinical trial, Co-Identify. Can you tell us about the program, its goals, what data you're capturing, and what you're doing with the data?
Yeah, thanks, Adam, and also thank you, Michael and Essentia, for having me on this podcast today. So we launched Co-Identify about 2 months ago. It's a program that uses smartwatches and wearable devices to detect infection. And particularly, we're looking to detect COVID-19, and it's spearheaded by my colleagues Jessalyn Dunn, Ryan Shaw, and Chris Woods. I like to think about this as a digital biosurveillance platform, and it really started because our team had previously developed what we call digital biomarkers of infection. Jessalyn Dunn, when she was at Stanford working with Mike Snyder, was able to capture a digital signature using wearable devices specifically for Lyme disease at its early times of infection, and that used normalized heart rate as the measure. Our Duke studies over the last decade have been focused on pre-symptomatic detection of viral upper respiratory infections, particularly influenza, and we've used a number of wearable technologies to look at heart rate and heart rate variability, as well as temperature as early warning signs of infection, and have gotten good signals. So we launched the COVID Identify project to answer the question of whether smartphones and wearable devices could identify individuals vulnerable to infection, early signs of infection, and also to map out the illness trajectory. So we're collecting symptom surveys and in some cases laboratory testing from the participants, and we're correlating this with self-reported data as well as the data that we're getting from the devices, which is uploaded to our site. We have about 5,000 participants right now with global representation. It's not just in the United States, and our goal is to do this in literally hundreds of thousands if we can. We think the COVID Identify tool will allow us to discover non-invasive ways to detect early infection, particularly with respect to this COVID-19 pandemic. It's an opportunity to do surveillance on a broad population and really help us understand how wearable devices can provide useful information, not only for this pandemic, but for future pandemics, which inevitably will happen. So that's in a nutshell.
Yeah, fascinating, and right in line with the things that we've been thinking about and talking about, how these digital biomarkers, as you said, could reveal early indicators and really help with remote monitoring and diagnostics. So you mentioned the things that are available now, and if I'm right, you mentioned smartphones, smartwatches, and surveys, in part. What do you see as needed and possible next? If you were to begin to add in things, I know you mentioned temperature. What are the things that you would love to see to make this more feasible and maybe more accurate?
Well, first of all, I should mention that the types of devices we're looking at right now are Fitbits, Garmin devices, as well as Apple Watches, but that could be extended to an entire repertoire of available technologies that are commercially available. The Washington Post article highlighted a number of other platforms that we're not using, like the Oura Ring and others. So I think this is a real opportunity for this digital health community to get together and just figure out the answer to your question. What is going to be the most practical, optimal, feasible way to monitor a population? And to me, that's really the end game of us coming together as a community. Hopefully, these will be things that people are using in their daily lives and can be implemented across broad populations.
Yeah, absolutely. I think that ties in really well to Stephen, your work, right? You're providing commercial solutions, pushing the edge, introducing new capabilities.
Living on the
edge. Curious what you see on the edge. Where do you see this going? What do you think is possible now, maybe, with devices that aren't broadly used yet? And where do you see it heading in the future?
This is a fun topic for Valencell because I want to say it was back in 2008. We were experimenting with some prototypes, some wearable prototypes that were designed to pick up a variety of biometrics optically. So heart rate information, respiration rate information, even at that time, some information, some at least normalized information about blood oxygenation. And we started collecting data broadly to understand how well our sensors could pick up this information in devices that people already wear. At the time, primarily that focus was on audio earbuds, because people wear Bluetooth headsets at least a few times of the month. And if you can take a snapshot, we thought, well, this is awesome. We can take a snapshot while people aren't having to bother with it and then provide them information that can be used to improve their health. Well, one of the oddities that we saw was that when we track in heart rate variability back in 2008, we would see all of a sudden in some participants, their heart rate variability would just completely drop. And it would drop, and we didn't understand what was going on. They didn't say they were stressed out. No one had broken up with their boyfriend or girlfriend. There was no reason why the heart rate variability should just drop so dramatically. And this was right around the time, if you recall, of the swine flu. And what we found out was that those people 2 days later started having symptoms of influenza or the swine flu, and then they found out they actually had the flu. And so 2 days ahead of them even being symptomatic, we saw these dramatic changes in heart rate variability. And it was so profound that you didn't even need to do an analysis of, say, something more complex, like the time between heart rate peaks, that millisecond resolution that people use to do heart rate variability calculations. It was so dramatic that if you just looked at someone's heart rate, so if you looked at just their heart rate, it was so steady, their heart rate hardly changed at all. It was elevated and didn't change. That was an indicator. And we thought that was interesting. And at the time, the marketplace was not receptive to remote patient monitoring. You might recall there was a company, Teladoc, that really struggled for a long time, unfairly for a long time, because the medical field wasn't ready to accept this kind of technology. And now Teladoc's doing well, really well. And now this type of thing is getting a lot of attention, and I'm just really glad that it is. Because what a lot of people don't know is that the devices you already wear, such as the Apple Watch, such as some Fitbit devices, and such as a number of different devices, many of which use Valencell's core technology, already have the capability of providing metrics that can be used to let you know on a VOS that you are likely coming down with something. Now, it's very difficult to say exactly what that is. In the case of COVID, I think it makes it even more what makes it more complicated is the fact that the symptoms are not so universal. I mean, there's some symptoms that seem to be, but not really all of them. And some people don't seem to have any symptoms at all. It'd be interesting to find out through these studies that are being done now, if these people who are asymptomatic, you could see their body fighting that infection with heart rate variability and some other factors. So where I see this technology going is, where I see the wearables marketplace going in medical now is, whereas we were really kind of stuck in the consumer side because that was a low-hanging fruit for so long, we really are getting our doors knocked down now by industry that wants to develop remote patient monitors, part of what they already wear in some way or fashion that can track these things and use a combination of really accurate sensor modalities with machine learning to kind of connect the dots to make those judgments. Does that answer your question?
Yeah, absolutely. That's fascinating, especially the history part of it. The early indicators, and being able to see the heart rate variability and heart rate level, and how useful that is, at least as a flag that something's off.
Right. Especially what's important in that case is that you also have a confidence indicator that lets you know beyond any shadow of any doubt that the values you're reading are really right. And that's one of the things greatly missing in devices in the marketplace today, even ones that use our technology, is they don't provide a confidence indication for the researcher to know, can I really trust this data or not? And that's one of the things that really needs to change, because if you don't know if that data is accurate or not, you could really be making some poor judgments. And a lot of times it ain't accurate, I can tell you, even with our stuff.
So interesting question. I can't leave that without asking what do you think it's going to take, maybe not at a deep technical level, but at whatever level you think is appropriate, to get that accuracy. Is it something you see on the horizon that challenge could be addressed?
Yeah, the problem here, Adam, is not only one of accuracy. It's one of, this is the challenge, and this is one of the things the ASSIST program is focused on, is that it's how do you make something accurate enough that people actually will wear? And that requires you to have something that can a sensor modality that can be imperceptibly worn, which means people aren't charging it all the time, which is one of the charters for the ASSIST program. And so it really does take some major advancements right now in mechanics and biomechanics, as far as devices that can be worn extremely comfortably and be absolutely imperceptibly worn. But then also, for that to be true, they have to have a longer battery life. And so that automatically means that now you're looking at how do you store the energy for these things? How do you generate energy for these things? Or how do you process this data in a way that doesn't just burn it up? So I think a lot of those challenges aren't so much about the sensor modalities. I think we got some awesome sensor modalities. You're talking, the PPG and various different versions of it, There's thermography, there's photoacoustic spectroscopy, there is ultrasonic technology I've seen where just variety, all kinds of electrode-based technologies which have the pros and cons of sculptatory. Those modalities are really not the issue. It's more about how do you make those sensor modalities, those ways of sensing, extremely imperceptible to wear, in something that people just enjoy wearing or just completely forget about wearing. I think one of the things that would help is something like this. I'll propose something to y'all now. All of our customers at Valencell, most of our customers are making more sophisticated smartwatches. And now the reason they do it, so they're adding, more advanced GPS or more advanced screen technology or multimedia functionality to these wearable devices. Now that has the benefit of helping technophiles and sports enthusiasts who want that information. Now it burns a lot more battery life. I think where the market needs to consider, especially on the side of public health, is the opposite of a smart band. I call it an idiot band because it's the opposite of a smart band. Imagine now some probably wrist-worn device that is as imperceptible as a Livestrong band or even less. That all it does is accurately track your biometrics, and that's it, and send it to a platform. And has impossible battery life and impossible size. You could wear it with your favorite watch. I think something like that is where I'd like to see the marketplace go, which is not the direction it's going now.
Yeah, fascinating. Very cool. Well, a lot of what you just said sparks questions that I'm thinking about, for Jeff, but also very relevant to what Alper's doing. Alper, I want to give you a chance, maybe before I launch into questions specific maybe to what you're doing. Any response or thoughts about what you've heard from Jeff and Stephen?
Yeah, definitely. First, I'd like to thank you for getting me into this panel and bringing attention to the pulmonary health. In our modern day life, bringing awareness to respiration and breathing has been used for bringing consciousness. And this respiratory health is, or the pulmonary health is one of the things that we do not realize we are doing at the background, and it has a lot of information embedded inside it. So whether you are healthy or whether you have some sickness, there are some signatures there. And the idea is, whether we can track this or whether we can get this. And both Stephen and Geoff has been talking about the algorithm size. And I'd like to bring some attention to the device side. I represent Assist Center, which is a almost 9-year-old center at NC State University. And
ooh, 9 years, good Lord, y'all getting old.
Yeah, with the eyeballing. We have two visions in the center. The first one is self-powering of wearable devices. When we first came to the business 9 years ago, there were only a few of those in the market, and it was very basic. Now, for last 9 years, there was an explosion. Since our first day, we have been working on self-powering of devices by harvesting energy from the body. And the motivation here is, as Stephen said, the user compliance. If you do not, if you need to charge, the more frequently you need to charge your devices, the less acceptance that device has, and it just become it just sits on the shelves rather than on the arms or on the body of the subject. So continuous, always on, deploy and forget devices are required for vigilant monitoring, and we have been working on getting the energy from the body itself. And the second vision of the center is actually related to correlated sensing of health and exposure. So a lot of wearables from the day one has been focusing on the physiology of or behaviors of the subjects, but bringing a context, what's happening in the environment is quite important to be able to focus on the data and do a more precise and accurate prediction of what's happening. So the first medical application area we had in the Assist Center has been the asthma and respiratory health. Many of us do not realize it, but we take a volume of our environment inside our body with every breath we take, and it's a considerable amount.
Every breath we take.
Yeah, exactly. In the respiration and COVID sense, what is important is the oxygen content of this air. How much of it we get into our lung, how much of it gets into our bloodstream, how much of it used for burning the nutrients to generate energy, and then we have the residual material, especially the carbon dioxide, and how much we can get back into the lungs. So in this context, heart rate variability, respiratory rate, the arterial oxygen saturations are very important factors, and with Valencell providing wearable devices to look at all of these parameters, and with algorithms that Geoff and his team designing, I think there is great potential, and our focus has been how we can lower the power consumption of the main method, which is photoplethysmography, where you shine light. You know, most wearable devices has these blinking LEDs behind it, the green and red and infrared, and this is how you calculate heart rate and maybe respiratory rate and arterial oxygenation. So that is a very power consuming process. You are generating photons, and those photons require some energy to burn. So we have been focusing on how we can lower in our center the power consumption of it. And we have been using another algorithmic method, the compressive sensing, to be able to do so. If we go beyond COVID or oxygen content of the air, another thing that we have been looking at was the quality of air in the environment, especially asthmatic population is very sensitive, and they are also one of the most vulnerable population in this COVID era. To be able to predict their asthma attacks, we have been trying to understand or trying to provide devices that would give some context about the air quality, and we have been looking at especially ozone concentration and volatile organic compound concentration. On a wristband, we were trying to monitor these parameters, and we do not have too much algorithmic development context in our center. We have few researchers working on it, but we are trying to make these devices and available and generate the data. In this COVID era, actually, you know, we are unfortunately the universities are shut down, and we cannot go back to the lab, and we have been mostly generating ideas, and we were thinking how we can get our creativity and academic resources to look at the COVID problem, and we have been seeing an uncharted territory, which is, you know, great potential for academic researchers, which is this the use case, not the use case, but the wearable form factor of the masks. Now masks are getting into our lives. Now everyone is requiring masks, even when you are doing your shopping in the grocery store. So we were focusing on, you know, there is of potential in terms of analysis of respiratory health when you use the mask form factor, from breathing rate to coughing frequency, from VOC content, the volatile organic content of your breath, to harvesting energy from the heat of the breath and the airflow of the breath. There is a lot of potential in that. So in the shutdown period, we were just focusing on writing proposals and planning, and we are looking forward to go back to our labs to explore some of these ideas and give more data to the algorithmic people to look at, in addition to what we have what we measure as regular parameters like heart rate, respiratory rate, and oxygen saturation.
Yeah, that's been really interesting. That I think we all kind of hate the thought that we'd be wearing masks routinely, but in the context of pulmonary and monitoring, yeah, interesting to think about all the potential there. Jeff, I want to come back to you, give you a chance first to respond to anything you've heard from Stephen or Alper, and then also kind of curious about some other aspects in particular of what they've said and what you said, but I'll there first.
Yeah, thanks. It's also great to hear the exciting work that Steve and Alper are engaged in. And I really appreciate that if people don't wear these devices and they're not simple to use and they're sort of effortless, that we won't get any of the data that we're talking about. So I really think focusing on the factors that will get people to not, just dispense with them. I mean, there was an old saying, fit, quit fit, because people would wear a device for a little while and then, a month later they would stop wearing it. So how do you train people or get them to provide the data will be necessarily dependent on just having them use these devices in the most simple and seamless way. But there was a discussion a little bit about accuracy, and from my perspective, at least, still a little bit of the Wild West stuff out there in terms of digital health devices. There's a lot of companies that are marketing their favorite device, and there's not, I think, hearing the panelists talk on this, there's not really an organizing entity that is thinking about the standards for digital health technologies. I think about it in the context of these are diagnostic devices, and the diagnostics industry has spent years trying to figure out concepts like analytical validity, meaning does the device usably measure what it's supposed to do, clinical validity, does it actually measure the phenotype or the clinical characteristic of interest, and then from an economic point of view, there's something called clinical utility, which means that if you use it, does it actually change the way people behave and or change the way change outcomes. So there's this framework that's already established for more traditional diagnostic devices. Be interesting to see if it could really be applied to the digital technology that we're talking about, so that people know when they go to a vendor, has this actually gone through a rigorous test? Am I going to get accurate information, or is this something that is an interesting plaything, but not going to really give me something that is medically actionable, which is, I think, what we're talking about today. These are really serious clinical conditions. People have serious illnesses. If we're going to get them to use the information, we have to have a standard of some type to make sure that it's really accurate, clinically valid, and useful. I wonder what Steve or Alper think about that creating that standard, that those types of standards for these types of technologies.
Those standards have been a challenge for a while. When Valencell founded in 2006, there was the formation of a standard for interconnectivity of medical devices used primarily at home or outside of a hospital, called the Continua Alliance. And the Continua Alliance, its focus was, before they came along, these respirometers and these ECG, Holter monitors, blood pressure cuffs that were connected, it was like a trailer park of protocols. And this caused a problem, because if the grand visage was to have these devices connect to some platform that could be used by professionals to make these diagnostics and to get early indications of various different events, and also ultimately reduce the cost of healthcare. But it was all over the map about how this data was collected, and so the Continua Alliance formed, and eventually they kind of basically kind of faded away. Maybe the organization is still around, but after the advent of Bluetooth and other technologies that became more of standards that people started using. But then there was still no standard about how to, with some of these newer technologies, for example, photoplasmography, which is, as Alper mentioned, is the primary sensor modality in wearables, which basically looks at changes in light scatter that happen as blood flows through your body. That technology is an ancient technology, but it didn't work in wearable devices. It didn't really work outside of hospitals. And wearable devices brought that technology into play, but then there was no way to judge how accurate were these devices. There was no standards for it. They were consumerized. So one of the things that's happened is the Consumer Technology Association has had to develop their own standards. And Valencell is one of the members of CTA's Digital Health Standards Committee. So we have been developing our own standards just because of the vacuum that's been there in leadership. I think that we've done a good job, as good a job as we can do. I wish that we had more feedback and more participation from the traditional medical field. Maybe that'll happen. It'll be interesting to see in the Consumer Electronics Showcase in January that happens in 2021, if more of the consumer technology is focused on digital health, and if there's even more of a participation from the traditional medical industry as opposed to simply more on the consumer electronics side.
Yeah, I echo with what Steven said, and IEEE, the Institute of Electrical Engineers, has some efforts for standardization, but without a proper standardization, it's going to be difficult for medical world to accept these data coming from the devices. We were talking to some medical doctors we collaborate, and they were saying that one of our nightmares is for an asthmatic kid, one of our nightmares is a parent coming with their iPads and showing some data on that iPad and trying to let us make some comments on that, because we do not know the context, we do not know the device. So there are two different kind of device groups. There are, as Steven said, the consumer products, and then there are medical devices, FDA approved, and once something is FDA approved and prescribed, its price become 10 times more than its consumer product counterpart, and it makes it difficult for people to basically for everyone to have that device. So there are more consumer devices in the market or in the current practice because of the price reason and also availability. And there are less FDA approved devices. So that is an important concern. So the data is mostly coming from consumer devices, and my hope is with these, some medical schools offer digital health as a program to their medical doctors. So as new generations of medical doctors are getting trained with the mindset of digital health. And my hope is in that new generation, and with the traditional generation or traditional methods, I think if we can, in addition to standardizing the devices, if we can standardize the data outcome, like people do not like looking at the data itself. They want to see information. Beyond that, they want to see some recommendation for decision making. So taking data, turning it into information, turning it into some actionable feedback, and doing in a standardized way will help for this generation of doctors to accept these technologies, or caregivers or medical caregivers, and the next generation hopefully will also be incorporating consumer devices.
Alper,
can I just
the comment you? Oh, sorry. Yeah.
No, thanks. I just wanted to say that I see the divide between the consumer and the medical grade devices, but the average consumer just doesn't understand the difference. And I think, as you said, Alper, providers, clinicians are going to want to only use devices in their patients that may have FDA approval or something similar to that. So at least in our work, if we're really going to go to develop something that is going to be a useful product for patient care, having obviously clinician input on the needs for the clinic, but also regulatory input early on is something that we subscribe to. And I think what is a disservice right now being done to the community, because consumers just don't see the difference between something that might have gone through an FDA approval process and something that's being marketed at a consumer electronics show. And I think we can probably do better than that.
Yeah, definitely right on this point. There's two things we're seeing from inbounds from the medical marketplace. One is the absolute need for FDA approval or regulatory approval abroad, critical for anything we're doing in the clinical side. But there's another thing too, and that is, even if something is FDA approved, it doesn't mean it works. I mean, the FDA, first of all, they make mistakes all the time. I could go on and on forever about that. And they have to pull products because of mistakes that they arguably they make, or certainly that the researchers make from time to time. But it's more than that. Things that get approved sometimes just aren't useful at all. Or there's built-in resistance. So give you an example. So, you know, blood pressure is a great example. Valencell has a technology for estimating blood pressure. That technology has not gone through an FDA approval yet, and it's going through those processes, and that takes a while. But blood pressure monitors, the blood pressure cuffs that most people are familiar with today use a technology called oscillometry. It's an oscillometric type of measurement, and that style of measuring blood pressure was around for a long time before the medical industry accepted it. So it was regulated, it was approved, the FDA accepted it, and doctors still did not want to use such a device because they weren't familiar with it and they didn't know how well to trust it. It was for good reasons. But you're talking about a long time from the invention of that oscillometric technology to the time it actually got in the marketplace. I believe by the time it got in the marketplace in a substantial way, a lot of the core patents had expired. So you could see how much of a challenge it is to bring in something that it looks just like a cuff. I mean, it looks, you know, the only difference, it doesn't have a way for your stethoscope to connect to it. But even that small difference had a tremendous amount of resistance. So step one is the regulatory aspect, but step two is what's going to encourage the medical industry to accept wearable technologies. Now that second one, that acceptance, I think, is what has changed with COVID. I feel that because now we know that for the foreseeable future, there's going to be a lot more just by the fact that superbugs exist, and COVID is just one example of one. In this era, there's going to be a need, and it's accepted now by even physicians in their local offices, that there's going to have to be more remote patient monitoring. And that really means that now devices that are easy to use become more important. And I think now there's a push for the medical field to accept technologies that haven't been traditional as long as they've been medically approved.
You know, this is really
for a second.
Go ahead.
I think you raised a number of really important points, Steve. One is that I think the current pandemic is a catalyst for potentially catapulting digital health into the forefront with telemedicine and other types of devices. But in the more traditional sense, even pre-COVID, getting a clinician to actually use something that's not in clinical guidelines and that's not reimbursed by payers is often the biggest stumbling block, which goes back to the utility function. And at some point, out COVID aside, we need to be able to prove that it's really cost savings or cost effective to actually use a digital solution for a particular disease. And then the payers will jump on board. Clinical trials will probably need to be done in some cases, maybe more cases than you probably want to think about. But that's really the standard of how medical, practitioners view their world, is seeing something proven in a more rigorous type of study than is currently being done in the field. And that's what gets payers to say, we're going to actually pay for this. So I think the other part of the stickiness of these things is if people have to go out and buy these things, it's just going to create a digital divide in terms of the haves and the have-nots and the people that can afford it and people who can't. But if insurers will actually see the value and reimburse for this, then there's a real opportunity to reduce that disparity.
And there's so many important aspects there. I'm really excited to hear drawn out from regulatory to accuracy and standards and reimbursement. I think we're going to have another panel just on adoption and getting these things into practice. I want to bring it back for a second to pulmonary and start with one of our audience questions. Eric Kloss asked, can anyone speak to the concept of wheeze detection or the use of an auditory relay product that detects a difference in breathing rhythm from a patient's norm? And I'll start with Alper because I know this is an area you've touched on.
Yes, the microphones from a device point of view, my microphones are great because they are not like other active devices where you need to generate photons or generate RF energy. It is just passive and it is just listening. So the challenge with those devices is there are a lot of noises out there. It starts with the environmental ambient noise, and it goes to a lot of times these devices are not attached to the body, but it is on some sort of wearable that is touching to the body, and there are a lot of noises coming from the friction and that contact. So once you eliminate all those noises, background noises, then there is some algorithmic potential in Assist Center. There were in the past and still algorithmic efforts to get the wheezing frequency and duration with wearable devices, wearable microphones. We have been, wheezing is mostly related to, I think, asthma related symptoms. And we were talking to our medical collaborators, and they were telling us if wheezing started, it is too late. You need to be able to predict before wheezing starts. So they were basically asking us to look at coughing frequency more than wheezing frequency. Which is relatively easier for us to detect because it's a sudden burst of sound, and the challenge, of course, is whether it's your own coughing or it is your if you are sitting next to someone watching I don't know, a TV show, whether it's coming from
or you sit next to me and I'm singing falsetto, bursting out all the time. I can.
Yeah, so this is kind of my input. We have looked at it. Wheezing is definitely with wearable microphones is detectable. One compliance issue is to be able to detect wheezing, you need to collect relatively high frequency audio. And if you are transmitting this data to the cloud for processing, then your private conversations are being transferred to the cloud. So people kind of do not like that idea, although it needs to be some on the edge processing rather than on the cloud processing.
Yeah,
I promise I won't seem living on the edge again, but I do have a comment about this. So, Valencell, we've done a lot in our earlier past. That's an interesting way to phrase it. Our early days, we did a lot of work in auscultatory analysis. The ear, for example, is a great place to measure body sounds. Mm-hmm. And we kind of put that technology on the shelf, in part because a lot of the audio processing that was required, audio has so much content, but the processing could be a total pain. And so we kind of shelved that technology for a while. And there's two comments I have about this in particular. One is I see a lot of promise for edge-based processing of auscultatory information, body sound information that is, using hearing aids. And, Valencell, we are in hearing aids now, and we have a partner, Sunion, that distributes hearing aid speaker drivers, RICs, receive in canal speaker drivers that have our technology embedded in it. And that's one of the ways that we can take advantage of that auscultatory analysis, just in a device that people wear anyway, every day anyway to hear, especially people who might be more at risk. So that's really interesting there. Another thing about auscultatory analysis is I feel that its real power will come from sensor fusion, where you can leverage other senses to help improve the processing localized processing required to process that auditory information into things that are useful.
I'd like also make a quick comment on this. So I had one of my engineering students had a friend who almost died of asthma. And so he and his friends got together and created a Bluetooth-enabled FEV1 device that measures the forced expiratory flow from the lungs at 1 second. And it's 3D printed. It reports to the phone, it reports to the doc, and a wheeze is already maybe it's too late. You really want to have somebody getting feedback at home on whether their bronchioles are constricting and they need a medication adjustment so they don't actually end up in an emergency room in a catastrophic situation. So a lot of these devices I think are super important to maintaining the health of asthmatics and people with lung disease. And I just wanted to say that I think there's a lot of devices now on the market that are actually doing the FEV1 measures remotely as well. So it's a really important part of the arsenal for lung disease.
Jeff, what you said reminded me of an important point on remote patient monitoring. At Valencell, since we are technology provider, we get a bunch of inbounds from industry for a bunch of things, some of which we can service, some of which we can't. Sometimes we direct folks to different organizations. For example, oftentimes, well, at least a few times, we've directed people to North Carolina State for things that we just didn't have. And the big early adopters for these types of technologies right now haven't been the medical community as we described it now for remote patient monitoring, but oddly enough, pharma. So we've gotten a number of inbounds from pharma brands that are looking for ways to connect the dots between people's lifestyles, their biometrics, and the medications they're taking. One of them is asthma. So, for example, using a wearable device, can they see from that wearable device when someone ideally should take the medication and that they have been taking it as a way to combine, for lack of a better term, I guess, combining digital health with traditional pharmacology. And that is really interesting. And that's where we're seeing the earliest adoption. That's where we're seeing people who are actually willing to pay us to advance this space. And maybe a lot of the advancements will happen from those early adopters first before they are more widely adopted in the remote patient monitoring space.
I want to get one more. Actually, I'm going to combine a couple of audience questions that I think are really important. Maybe a minute each if you'll respond. It's on the topic of data collection, and maybe some processing that's done to ensure as best we can now that it's quality data. So I know, Jeff, the COVID-Identify, collecting a lot of data. Stephen, you've already been talking about data. A lot of processing there, especially edge versus in the cloud. Alper, you talked about the same thing. So maybe just a minute each. Jeff, thoughts about kind of how you're doing that data, aggregation and maybe some processing.
Yeah. So I guess the way I would look at it is, let's not let perfection be the enemy of the good. And we know that there's a lot of, data variability, particularly on remote devices of the kinds that we're talking about. So we're counting on effectively both strength in the numbers and some baseline quality of the devices that we're using, as well as the importance of the clinical data or the self-reported clinical data that we're capturing to give us a sense of what's a signal and what's not. But as others have mentioned, a lot of this will depend on using fairly sophisticated statistical methodologies to tease out the signal to noise from data variability. But this is the real world, and I think what we're trying to do is figure out what will work in the real world. We don't want to create a super standard like a clinical trial to impose on this. We really want to use the data that's out there.
Stephen, your thoughts on best practices or how you should handle data when we're talking about getting beyond the device itself?
At Valencell, since we're a technology provider, we're B2B. And, we don't make our own in-use products. We do make sensor modules that get integrated into those in-use products, whether they're wristbands, armbands, clothing, earbuds, hearing aids, all kinds of stuff. But we don't make the end product. What we found, however, so traditionally what I'm getting at there is traditionally we haven't had to, and it hasn't been our purview, to address the in-use data side, because we provide core technologies, and then our customers traditionally have sent data collected from our sensor modalities to their cloud. What we found was that we had to get into this game because there were some unmet needs in the B2B side. So for example, it used to be if you had a Valencell development kit and you wanted to study our technology to integrate it into your wearable device, then you had to collect that data, store it locally, and process it locally. What we found is that we needed to develop cloud resources to make it easier for our customers to do their experiments with our development kits and hurry up and develop the product. And from there, it kind of turned into the understanding that we needed to provide some additional analytics that ultimately may be used at the end user level. So for example, imagine a situation where you have a smartwatch, I guess, since they're more commonly known for modalities there. And that smartwatch is generating a variety of biometrics. That data is, say, going to our partner's cloud that they're using to service the people using those devices. There's some analysis that may need to be done that they don't want to deal with, but we know how to do. And we could do that in the cloud and provide that to them, not to the end user, but to our customers. So that's mostly how we've been focusing our data aggregation efforts because of our relatively unique position on servicing from a B2B perspective in the wearable world.
Yeah, very cool. Yeah, that's interesting to know you moved into that space. It makes a lot of sense for your customers. Alper, doing studies, you mentioned that there's a lot of data being collected. Any thoughts on what we should know?
I think one of the potentials is on the data fusion side or sensor fusion side. One thing you can do is when you are collecting data, you can ask your subject to enter some input on whether data would be, whether it's a context that data would be reliable or not. But that is going to be any device should be wear and forget. It should require minimum supervision by the user. In that context, we can get help from the other sensors, like in a, for example, case of PPG. You can first look at the IMU data or other, if you have an EKG on board as well for heart rate variability, you can use that kind of sensor vision. So asking different sensors about the reliability of your data would give you an idea about what's happening and whether the data would be, how you can process that data as a dependable data or with the data that may need some more processing. We have some efforts in the center. Edgar Lobaton is generating a signal quality index when he collects data. And that then we go back in our experimental platforms and try to find out when the signal quality goes low, why does it go low? Because a lot of times our devices are not in free range subjects, but they are in more like controlled environments, and it ends up that something gets out of the control, and we try to find out what it was getting out of the control. So in the free range context, signal quality index can maybe, or did that kind of reliability measurement on the data would give some information or some actionable feedback to the user saying that, oh, your device got detached. Can you just push it a little bit to improve your data? Or I don't know, we just need some, data right now. Can you just sit for 30 seconds and be on a still stationary position such that we can collect some data? So that kind of, I think, user interaction, although, we try to minimize the user interaction, but in the meantime, that kind of think if it is important for the user, you can subscribe them and you can recruit them and you can get them collected more reliable data, I believe.
Yeah. We're getting to the end, and I might have to speed talk here in a second, but I want to give one last question to you each in a sentence. I'm going to try to really contain it. What would you like to see for pulmonary monitoring in particular, where we could go with that to really improve our ability, to address unmet health needs in that area right now? Jeff, we'll start with you.
At the risk of being repetitive, I'd like to see a very direct pathway from understanding the unmet medical need, development of the appropriate device, and its approval by regulators as well as payers in order so that it can be widely adopted.
Yeah. Stephen, what's needed next?
I think that there's two big things. One of them is on the technical side, one of them is on the market side. On the market side, the industry has to don't let the importance that has been realized largely due to COVID of this technology go to waste, because that importance needs to be realized to make sure that the industry is more accepting of this technology, that this, even if COVID resolves itself somehow, this is not going to stop. There's going to be more, and use that energy to make sure we're better prepared with remote patient technologies. That's one thing. A second thing is, like I said, I think there needs to be substantial developments on the I'm going to call it biomechanical side for having these wearables truly imperceptible to be worn. And there's actually a lot of work that needs to be done there. It's not just, I'm just going to make things smaller. It's it's got to be much smaller and possibly lightweight, and possibly, you don't even notice it's being worn, and you could wear it different ways, and still get the accurate information. It's quite a challenge. So those two
makes a lot of sense. Alper, I apologize. I'm going to have to wrap us up without getting to you. In particular, well, first of all, thank you. Thank you all. This has been a fantastic panel. Really great exchange, a lot of great insights, so I appreciate it. We will have another panel in 2 weeks. I believe you can perhaps see it on a slide coming up, and you can certainly find it on events at dhitglobal.org. June 12th, panel on remote cardiac monitoring. So we'll pick up this discussion, have some overlap, but some new perspectives as well there. I do want to go back a slide. Apologize to my assistant here. Also wanted to thank our panelists, or rather our program and innovation champion. Couldn't do this without their help. Wanted to finally get to something very exciting. We're launching a virtual incubator. You can find out more about it at dhit.crowdicity.com. At the end of this, you will be able to be directed to that. This is helping us put talk into action, take the things that we're hearing and really bring the innovator community to solve some of these challenges. So I'll let you go of that, find out more. We're at the end of our time. It's been a fantastic discussion. Really, really appreciate everybody. So we'll close out. Hope to see you all again in a couple of weeks. Have a great day, everyone.
All right. Y'all have a good one.
All right. Take care. I'm Adam signing off.
Thanks, everyone.